Hello, everybody. My name is Mike Smith, and I'm glad to be talking to you today about communicating to non-academic audiences. This is the video component of this session. We're going to have a live component coming up soon where we're hopefully going to have more direct engagement and back and forth communication about this. So I am looking forward to that, and I hope that this video is helpful to you thinking about communicating to non-academic audiences before we meet together to talk about it. So before we start, I want to give my biased opinion about the importance of communication in epidemiology. And I think, based on my experience, that an epidemiologist who is twice the communicator and half the analyst will be about 3 times more effective than someone who is twice the analyst and half the communicator. Again, this is my opinion. Based on what I've seen in my career, and this is especially true, I think, for non-academic epidemiologists, for people that are working in applied settings. In my experience in applied settings, your most valuable resources are your partners, and being able to communicate to those internal and external partners clearly is going to make you much more effective in your role as an epi. So what I want to talk about in this communication session is a few key points. The first one is where does communication about data often break down? And I want to talk about this in terms of communicating with internal partners within our organizations, and so that's going to be the focus of this video. And then while we're all together, I want to focus more on communicating with folks outside of our organizations. And then we're also going to talk about how do we improve our data communication and our data storytelling, both within our organizations and outside of our organizations. And throughout this video, I'm going to keep going back to an example from newborn screening, right? And this is a communication example that I experienced between data and program folks in my career, and I think that it's a helpful illustration. I hope so. So when I'm talking about the newborn screening program, you may be very, very familiar with it, or you may not. So I'm going to give a quick overview of it. Basically, it is a program where when a baby is born, about a day after they're born, usually between 24 to 48 hours, unless there are other risk factors that are more important to deal with at that time. But usually, within 24 to 48 hours, the baby's heel is pricked and a little bit of blood is taken from their heel and put on a newborn screening card. That card is packaged and mailed to the state laboratory, or sometimes it's an academic laboratory that contracts with the state, to be tested for a wide variety of metabolic and genetic conditions that generally and ideally are severe conditions, but if there's early identification and intervention, the prognosis for these children can be greatly improved. So there are a few steps that I want to focus on that need to take place in this newborn screening process. One is the baby is born, the blood is drawn is the second step that I want to think about. The hospital ships that newborn blood screening card. The lab receives the newborn blood spot screening card. The blood spot is processed at the lab. The tests are done on the on the blood sample, and then the results are communicated back to the healthcare provider and the family. Right? Of course, there are different time processes for communicating those results. If the sample tests positive for one of the conditions it's being tested for, it's important that those results are communicated very quickly. If the sample tests negative for all of the conditions, then it's not as critical that result gets communicated as quickly. So those are the 7 steps that I want us to think about as we go through this example. Now, several years ago, there was an investigative journalist at the Milwaukee Journal Sentinel who wrote a series of articles called Deadly Delays. where she was looking at the newborn screening data and also telling stories from people from different parts of Wisconsin and also the United States that experienced basically failures of this newborn screening process, where things did not happen in the time frame that they were supposed to happen in, and there were bad results that potentially could have been prevented. When this article came out, I was working at the state health department in South Carolina, and the maternal and child health bureau there, and at least within our agency, this really shook up the newborn screening program. And my impression from the field is that it did in other states and areas as well. So this was a really big event, because we had staff managing this program. We had data around this program. We were utilizing this data for block grant reporting and things like that, right? So we had the people, we had the data, we were asking questions. Maybe we were asking the right questions. Even if we were asking the right questions, and even if we had the right answers, it wasn't enough because everybody wasn't on the same page and of the same understanding about what the right questions were, what the right answers were, right? So at the very least, in an ideal setting where we had the right data and we're asking the right questions, that communication barrier, if that communication barrier exists, then having the right data, having the right answers, having the right questions doesn't mean much, because we can't make the right decision unless we're able to communicate all those things, right? So all of these things are necessary to have good decision making in public health and for a public health program, right? Communication is an absolutely essential ingredient, but so is asking the right questions, having the right data, and all these things. So in thinking about some of the ways these communications break down, it's, I think, useful to think about some of the roles that are often involved in these internal communications. So let's think about program administrators. So program administrators, they are responsible for the oversight and operation of these programs, and they need the right information to make good decisions, and sometimes those decisions have big implications. They're often good at asking lots of questions, but most often don't know the right questions to ask when it comes to the data. Usually, program administrators do not have a background or training in epidemiologic methods or statistical methods, right? Their background doesn't include that training. They're not trained to think that way. Their experience doesn't usually prompt them to think that way, right? So it's important to understand the perspectives that these program administrators have and the expertise that they're bringing to the table, and the perspectives that we have as data folks, right? We're data producers, data analysts, epidemiologists. Often we're good at running SAS data R programs to get an answer, right? If you give me a question and you give me a data set, I can get an answer. It may not be the right answer, right? SAS will give me an answer, Stata will give me an answer. It may not be the right answer, so getting to what the right answer is important, but also answering the question that the program administrator is asking, or the question that they're trying to ask, because again, they're not speaking data language, right? So sometimes we have to think about getting the answer to the question that the administrator thought they were trying to ask, and then communicating, explaining that data in a meaningful way to the administrator, right? So there's two sides of communication here, two instances of communication. One is understanding the question that they're asking and having conversation to make sure you know what they're asking and what they're trying to ask, trying to use the data to answer that question if you can, and then explaining the results in a way that is meaningful to the administrator and helps them make a decision, right? And to try to illustrate this process and the way it often goes, I'm going to use what I hope is kind of a silly example. So this is a health administrator, and they're very busy. They are so busy that they have four arms, right, to try to get everything done. They're so busy that they're still using a flip phone because they haven't had time to go and upgrade their phone plan. And they are working away. And then this is the data analyst, the epidemiologist. They're anonymous. They are sitting at their computer crunching the data, right? And the administrator says, "So, what do the numbers tell us?" And the epidemiologist says, "The numbers tell us that there is no statistically significant evidence of a positive linear trend between ice cream sales and property theft in the zip codes of interest." And then the administrator says, "What? Can you clarify that?" And now, when the epidemiologist hears the administrator say, "Can you clarify that?" they get really excited. They say, "Oh, somebody's interested in my methods. Somebody's interested in my analysis. This never happens. Oh, this is so great. I'm so glad that you asked." So what I did was I did a linear regression model, and I restricted to the zip codes of interest. And I used the theft rate as the dependent variable, and I used a continuous ice cream sales variable and a categorical year variable as my predictor variables. But really what I was interested in is the interaction between year and ice cream sales. So what I did was I looked at the least squared means for ice cream sales across years to assess that interaction and determine that there's no statistically significant linear trend there. Isn't that cool? Does that help? What do you think? Is that useful? Right. So this is kind of a silly example of total miscommunication between the administrator and the epidemiologist. To put it in more real terms, the way it may be more likely to happen in your experience. Let's think about it in this newborn screening example. Again, there are a few different key steps that can be time-stamped in this process. One is, when is the baby born? We talked about these a minute ago. I'll go back over. When's the baby born? When is the heel stick done and the blood drawn? When does the hospital ship the specimen? When does the lab receive the specimen? When does the lab process the specimen? When does the lab test the specimen? And then when does the lab communicate the results, right? So these 7 steps. So let's say that the administrator asks, do we have delays in hospitals sending newborn screening blood spots to the state lab? And the epidemiologist says, let me crunch the numbers and I'll get back to you. And then they get back to the administrator and say, across all hospitals, there was an average of 6 days between births and the state lab processing the blood spots specimens. Now, has this epidemiologist answered the administrator's question? What do you think? So the answer is that they have given an answer. They have not given the answer to the question that the administrator is asking. So the administrator is asking about, if we think about our 7 steps that we just outlined, she's asking about the time between steps 2 and 3, right? Not birth, but the heel stick and hospital sending the sample. So asking about that time period. The epidemiologist is answering from birth to processing, right? So the epidemiologist is answering from step 1 to step 5 when the administrator is asking about from step 2 to step 3, right? And so that's a miscommunication. That's a communication breakdown, and it can be easy to miss in practice in the real world, right? This seems like they might be answering the question, and you can perhaps imagine a scenario where the administrator says, okay, thank you, and goes back to their office and makes a decision based on this 6 days, and maybe they're working with the State Hospital Association, and they're bringing in a group of hospitals, and they're launching a quality improvement program, and they're wasting everybody's time because they're looking at the wrong data and not using the right data. And so maybe this damages the credibility for the program and the agency. And, these things can cause problems, right? So in South Carolina, where I was working, the situation that we were in was we had the date and time of birth, we had the time when the heel stick took place. We did not have when the hospital shipped it. We did not have when the lab processed it. We had when not when the lab received it, but we did have when the lab processed it, right? So these were the time points that we had. So it's easy. It was easy for me to give this 1 to 5 answer or this 2 to 5 answer. I didn't have the data to give this 2 to 3 answer, and that's what we needed. But it wasn't in my data set. In fact, we were getting that data, but we were throwing it away. It came on the postmark on the envelope that the newborn screening specimens were shipped in. Right? So we had this data on the postmark. We were opening the envelope, throwing away the envelope, processing the newborn screening cards. Right? So when we communicated about this, we realized, okay, I see what you need. You need this. I have this. And talking about it and talking with the lab staff, no, you know what? We can get these 2 time points that we're missing and that we need. We just need to get that from the envelopes into our data set. And so we brought in a very gracious graduate assistant who did the mundane but very important work of entering these postmark timestamp data into our data set. And not long after that, we got a scanner that we could use to scan the barcode on the envelope to put it into our data set automatically. And then when we had that data in our data set, I could provide the information to answer this question, right? The time between when the hospitals were drawing the blood spot and when they were shipping it. And what we found when we had the data that we needed to investigate this question, what we found was some of the hospitals, especially the smaller hospitals, were waiting until they had several blood spots to take it to the mailroom, right? So they weren't sending them every day, because if they just had 1 or 2 in a day, maybe it wasn't worth the trip to the mailroom to send these. So they were going to wait until the end of the week when they had enough and batch them and send them, right? It was a problem that once we identified it, it was a pretty easy problem to correct, right? They just didn't understand that this was a problem, that this was an issue. And once we were able to communicate that to the hospital association, they stopped doing it. They started shipping them the same day, and the problem was solved. But without this communication, it would have been easy to completely miss this problem and misdiagnose this problem and waste a lot of time and spin our wheels and not get much done, right? So these communication things that happen with our internal partners that we work with, they can be really difficult to identify, right? So it's worth our time and worth our while to think about this. So the situation that we have is that we have analysts who, most analysts and EPIs, they don't have a background in training in health administration, right? We have background in training in epidemiology. So we have analysts with little programmatic or subject matter expertise, often, and those are the things that are necessary for identifying hypotheses and selecting the relevant variables that we need, right? I need to know that these steps are in the process, and they're the important steps that we need to focus on right now for the data analysis. And if I don't know the program, or if I don't learn about the program, then I'm not going to be able to understand that, right? We also have the administrators who have that programmatic and subject matter expertise that's necessary for identifying hypotheses and selecting variables, but they're not trained usually to think in terms of hypotheses and variables. Right? So do you see the communication need here and the potential for disconnect here? Often the result is that everybody is frustrated. Right? I don't know how many times I've heard program people say, I don't know why I even try with these data folks. Right? I ask them questions and all they say is, I can't do it, I can't do it, I can't do it. I don't have the data, I can't answer that question. No, no, no. I'm sick of it. I don't know why I even try to work with them. And I don't know how many times I've heard data folks and EPIs say, I don't know what these program people want from me. They ask me a question and I give them an answer, and then they ask me another question, I give them an answer, and they're never satisfied. I don't know what they want from me, right? The result is that everybody is frustrated, and that's not the worst case scenario, right? It's easy to imagine, and it happens often, a situation where people aren't frustrated because they don't even realize they've miscommunicated, right? We kind of just talked about this. The administrator asks a question, the analyst misunderstands it and gives the answer that's not to the question that the administrator asked, or miscommunicates the result, and the administrator misunderstands it, but they don't realize that they've had this misunderstanding, right? They have this miscommunication, they don't realize it. The administrator hears what they think is the answer to the question and goes on to make a decision with that information, and maybe they make a bad decision, right? We get into this field and take jobs in governmental public health because we want to make a difference for people, for populations, for programs, for policies that we care about. And we could have this situation because we're not communicating well, where we're making bad decisions and we're facilitating bad decisions that make things worse for the people, the populations, the programs, and the policies that we care about. Right? And that's the worst case scenario. So if you're experiencing frustration, it could be worse because you could not even realize that there's a miscommunication and be making bad decisions. So what can we do, right? I mean, and you can see how that can happen easily here, right? We talked about it. This could seem like this is the right answer to this question, and you could see how they could just go on and make a bad decision. So let's think about bridging this communication gap between data analysts and administrators. If you can be the person that can translate between the data folks and the program folks, right? If you can be that liaison, that communicator, that is a great place to be. Right? That is a position to be where you are really making an impact. If you can be the person that can speak the program language and you can speak the analyst language, right? Whether you work on the program side or in this case, more likely the epi side, if you can be that person, you are very impactful in your organization. You are probably very influential in your organization. Even if you're at the bottom of an organizational chart, you probably have a lot of influence because you can quickly make yourself the go-to person for figuring out what the implications of the data are for the decisions that need to be made, right? And that is a great place to be for an epidemiologist that wants to have an impact. It's also not coincidentally a good place to be career-wise, because that can help to give you a really good reputation in your organization and with your partners outside your organization, and that reputation often can lead to opportunities, career opportunities down the line. So this is a great place to be. Now, and trying to put yourself there is a great thing, but there are challenges always that are outside of your control, right? Sometimes organizational culture, right? The leadership in your organization that's setting the culture makes this difficult. Sometimes institutional inertia, what I call institutional inertia, right? That's just the way we've done things around here, the way we do things around here, the way we've always done things around here can play a role and can make this difficult. The good news is that that one side understanding this disconnect and making a concerted effort to bridge this gap can go a long way. Now, I don't want to discount the challenges of being in an organization that doesn't value this and that doesn't support this, and that if you have a supervisor that does not think that this is important, or if you have a situation where the data folks sit at this lunch table and the program folks sit at this lunch table, and they make dirty looks at each other, and they don't talk, and there's animosity there. Like that's a hard situation to overcome. But if you are an epidemiologist that that works with several programs, maybe you can find one that's willing to engage on this type of communication, and maybe you can make an impact there, and maybe others will recognize it. If you are willing to try to be this person that bridges this communication gap, that can go a long way in many instances and circumstances. Okay, so let's think about where do these communication breakdowns occur, and this is a decision-making process that comes from an article that Thomas Davenport wrote in the Harvard Business Review magazine, and it was compiled in this book called The Harvard Business Review Guide to Data Analytics Basics for Managers. I think it's a really useful book. There's like 22, 23, something like that, articles from different Harvard Business Review magazines about data analytics. And I use this book in a class that I teach to health administration students so that they can be more data savvy and so that they can be better communicators from the other side of this process. I think that this is if you want to pick it up, you can get it for $20 or less on Amazon, or if you have a better, more local place to get books, that would be even better. But this is from an article in that book called "Keeping Up with Your Quants." So the first step that Davenport outlines is recognizing the problem or the question, and in this step you frame the problem or the issue. Right? You can frame it positively. We have an opportunity to improve the way that we serve the mothers and babies and families in our state, or it can be framed negatively. We have this issue, and moms and babies and families are at risk, right? And you can see that there's already individual and subject matter expert influence in the way we're approaching these problems and issues already by recognizing the problem or question, and then review previous findings. How have others tried to solve similar problems? What have other states or jurisdictions done? Is there anything in the literature about this? Then model the solution and select the variables. Formulate a detailed conceptual model that represents a detailed hypothesis. Right? Outline all of the 7 important relevant steps. Collect the data. It may be secondary data that you already have. You may have to do some primary data collection, or it may be a mix of both, right? In our newborn screening example, it was a mix of both. We had some data. We also needed to get some data, right? So that we had everything that we needed. Then analyze the data. We have to make sure we're checking the assumptions and using the appropriate statistical techniques. We analyze the data and then present and act on the results, right? Use the data to tell a story, inspire action, make decisions. Right? I think that this is a pretty good model decision-making process, and I think it's going to be useful for our thinking about these things, because what I want us to think about are the handoffs of information between program folks and data folks in this process. Right? We have this first step that is usually more in the domain of the program folks, recognizing the problem or question, framing it, and then we have this second step, reviewing previous findings, that may be in the domains in some places and with some issues of the program folks. Maybe it's in the domain of the data folks, depending on the question or the issue. But then we have these 3 steps that are clearly in the domain of the data folks, right? So there's a handoff of information here, an opportunity for miscommunication here on the front end. And then as EPIs and analysts and data folks, we present the results. We have to communicate those results, but in almost all situations, the administrator has to understand and present and act on those results. So there's a handoff of information here on this backside of this process. And so there are 2 handoffs of information, 2 opportunities for miscommunication. I think as data folks, we think about this opportunity for miscommunication, how we interpret the data and how we communicate those results. We think about that one more often than we think about this one in many circumstances. But recognizing that there are these 2 opportunities for miscommunication can make us better communicators with our internal stakeholders. So what can we on the EPI side do about it? I think that there are a few things that make us better at this communication. And the first, I think, is to care about what you're working on. If you care about the people, the populations, the programs, the policies that you're working on, you're going to be much more interested in learning about those things, learning the programs, learning the context that are necessary for this communication. And if you're working in an area that you don't care that much about, that's not ideal, but it's okay. But you have to recognize it, you have to admit it, and you have to, in my opinion, start making plans and taking steps to try to get to an area that you care about. Because you're going to be most effective in your career when you're working on something that you care about. Know what matters to your audience, right? If you're communicating to the program administrator, you have to know what decision they're trying to make, what they need, what their context is, what matters to them. Know as much as you can about the subject matter. This relates a lot to the first bullet, because it's a lot easier to know and learn about the subject matter if you care about the subject matter. But if you want to be a good communicator, you've got to know about the subject matter. You have to. And then teach. So I think of communicating data in a couple of different ways, depending on what my objectives are. Two of the main ways I think about it is either storytelling with the data or teaching with the data. Storytelling is if I want to communicate like a big picture idea with the data, and I really want my audience to care about that idea and to care about the bottom line, big picture of what I'm trying to communicate. If that's what I'm trying to do, then I'm trying to tell a story. If my audience needs to understand the details of the data and understand why those details are important and how they impact the decisions that need to be made, then what I'm trying to do is teach with the data, right? I want to teach the program administrator what these results mean so that they can use those results to make a meaningful decision or use those results to advocate to another level of leadership to make a meaningful decision, to make a meaningful difference, right? So I'm, in this type of situation, I'm thinking about teaching with the data. So, those are the big things in broad that I think we can start to think about, and you probably think about a lot of these things already, to try to be better communicators within our organizations. I'm really interested to hear what you think about this. I'm really interested in talking to you more about communicating within your organizations, and I'm looking forward to talking to you in our live session about how we think about these things to communicate with audiences outside of our organization. All right, that's a picture of my daughter pushing a pig in a toy shopping cart. So thank you very much, and I look forward to chatting with you soon.